We'll talk today about important topics. If we find batch calcification of the kidneys on X-ray, how we reach the likely diagnosis, how we think about the likely diagnosis. Is it calculi, nephrocalcinosis, hemochromatosis, amyloidosis, or polycystic kidney disease? Here, for example, the kidney and they call batch calcification. So it is batch calcification. So calcium is deposited in the renal parenchyma, which coincide with nephrocalcinosis. And nephrocalcinosis can be secondary to a condition of hypercalcemia. So if we find this hypercalcemia by blood test and found the calcium level is high, how we think about the possible diagnosis? There is two most important causes of hypercalcemia we should think about, which is hyperparathyroidism and malignancy, and both can account for 90% or more of the cases of hypercalcemia. So hyperparathyroidism or malignancy. Hyperparathyroidism, we have three causes of hyperparathyroidism, either primary or secondary or tertiary hyperparathyroidism. Primary hyperparathyroidism, it's not common in the population. It's about 1 every 1,000 of the people have primary hyperparathyroidism, and caused by single hyperparathyroid adenoma secreting high level of BTH. Occasionally we can find hyperplasia or rarely carcinoma of the parathyroid gland. In secondary hyperparathyroidism, the high level of parathyroid hormone is secondary to hypocalcemia. In tertiary hyperparathyroidism is long-standing secondary hyperparathyroidism when the parathyroid hormone increase for a long time due to the effect of hypocalcemia. What is called autonomous hypersecretion of parathyroid hormones occurs, and commonly it occurs in the renal disease patients. We'll find in this patient plasma, calcium, and BTH are both high, and the treatment would be parathyroidectomy. And other causes of malignancy causing high calcium level is multiple myeloma, lung cancer, breast cancer, or thyroid carcinoma. Other causes of hypercalcemia, which account for the other rest of the 10% of cases, is increased vitamin D, either by ingestion of vitamin D or granulomatous disease like sarcoidosis, increased vitamin D production. There is a rare condition called familial hypocalciuric hypercalcemia. In all of these conditions, where calcium level of high amount will find in the urine, the calcium level will be high in the urine. But in this rare case of familial hypocalciuric hypercalcemia, we find hypercalcemia, high level of calcium in the blood, but the 24-hour urine calcium will be low. And it is a trick in some questions with hypercalcemia come in the exam. We found in the top, for example, there is family history of hypercalcemia, and what is the next important investigation for this patient? So the answer will be 24-hour calcium in the urine, which will be found low. Other causes of hypercalcemia, drug like lithium and thiazide, immobilization, increase intake of calcium, and milk alkali syndrome. Talk now about the investigation, and before talking about investigation, I would like to talk first about the symptoms and signs of hypercalcemia. Mostly it is incidental if the calcium level is less than incidental, and asymptomatic if the calcium level is less than 3 millimole per liter. But after, in more severe hypercalcemia, patient can present with symptoms: general malaise, depression, bone pains, abdominal symptoms in some form of abdominal pains, constipation, CNS symptoms of confusion, and these symptoms affect these systems of the bone pain, abdomen, and neurological symptoms. Also can cause polyuria and stones in the kidney. To investigate hypercalcemia, we need to have fasting serum calcium and phosphorus, and associate also with parathyroid hormone level. We should find the low phosphorus or low normal phosphorus and high calcium in the case of hyperparathyroidism and some malignancy. If it is high, it can be found in other causes of hypercalcemia. For parathyroid hormone levels, we should find when the calcium level is high, is the parathyroid hormone is low. So in the case of hypercalcemia, if we find the parathyroid hormone level is detectable or elevated, it is inappropriate result and imply hyperparathyroidism. So because with calcium level high, parathyroid hormone should be low. In hyperparathyroidism, it increases the level of parathyroid hormone to increase the level of calcium, and the effect of calcium in parathyroid hormone is not occur as usual as normal situation. So both will be high, so imply diagnosis of hyperparathyroidism. If we find the high calcium level and the parathyroid hormone is as expected undetectable, so we should search for the other causes other than primary hyperparathyroidism. For example, if we suspect multiple myeloma, we can ask for protein electrophoresis. We can search for endocrine causes like thyrotoxicosis by thyroid function test, or Addison disease by doing a synectin test. And if we suspect malignancy, for example, bronchogenic carcinoma, we can ask for CT scan chest. Or if we suspect thyroid cancer, we can ask for ultrasound. Or if we find a nodule, we can take biopsy. Now the patient is hypercalcemic and we want to treat him. So we treat him with normal saline at high volume. For example, we can give him normal saline in the first 24 hours, 4 to 6 liters of fluid. And it is expected to correct the dehydration and also correct the CNS symptoms of confusion and lethargy. After hydration, we can think to give him furosemide, but be cautious about use of furosemide because it can cause electrolyte disturbance. So we can use biphosphonate with dehydration, and biphosphonate like bamidronate or zolondronate is very effective in returning calcium to the normal level, but it takes 2 to 4 days to have its effect by inhibiting osteoclast. And we can give in severe hypercalcemia bamidronate intravenous by infusion, 15 to 60 milligram over half liter of normal saline and over 2 to 8 hours duration. And we'll measure the serum urea and electrolyte daily, but don't measure serum calcium except after 2 days because the effect of biphosphonate takes this duration to have its effect. And normalization can take 3 to 5 days to occur. We can use other modalities in treatment like steroids, and especially effective in few conditions like sarcoidosis, vitamin D intoxication, and also can give effect with some malignancy like myeloma. Calcitonin inhibits the action of osteoclast on bone, and it is of rapid onset of action. Also some modalities of treatment We can think also of dialysis in severe hypercalcemia and not responding to rehydration quickly or biphosphonates, and if with renal impairment and sometimes with cardiac affection and risk of cardiac arrest. So in hypercalcemia, questions can come over some scenarios like batch calcification in the kidney. For example, asking about the causes of hyperparathyroidism, so he can give some tricks of calcium level is high, or parathyroid hormone is not is same is high of same time both, so we diagnosis will be hyperparathyroidism. So in the exam again, if both calcium and parathyroid hormone both are high, we think about hyperparathyroidism. If the question mentions there is family history of hypercalcemia and renal stones, and we think about 24-hour calcium level, which will be low in familiar hypocalcemic hypocalciuric hypercalcemia. And in the investigation, as we said, we think about calcium, phosphorus, and parathyroid. In the treatment, for example, he might ask about what is next essential step in the management, will be rehydration by normal saline at heart volume, 4 to 6 liters first 24 hours, and after that 3 to 4 liters, but according to the clinical response of the patient and also the kidney functions. And second, the most important modality of treatment is the biphosphonate. As I said, we think about other modalities like corticosteroids in sarcoidosis and vitamin D intoxication. And I think we hope you all the best in the exam.